Um, Dr. Ashika, I hope I'm saying that right, Dr. Sheik. I appreciate the opportunity to meet with you through this YouTube video. I apologize for not being there in person, but my university and my wife felt it safer for me to remain at home at this time due to the different events of the Middle East. I hope in the near future to be able to come to your country to meet with you in person, but I thought this would be the second best way to introduce you to a concept that we're very interested in working with you on. My name is Ken Moise. I'm professor of OBGYN and professor of pediatric surgery at the McGovern School of Medicine in Houston, Texas, in the United States. I also work at the Fetal Center at Children's Memorial Hermann Hospital here in Houston. I've spent the better 30 years of my career studying both clinically and in the basic science lab the disease rhesus immunization and its consequences in the fetus and newborn. In the United States, about 85% of individuals' blood type is RHD positive and about 15% RH negative. And until only recently, based on a study done in conjunction with AKU in the Dadu district, it was felt that the incidence of RH negativity in Pakistan was about 7.5%. But based on the study, pilot study done by Lisa Pell at Toronto Sick Children's in the Dadu district, it was determined in about 2,000 women that 83% were RH positive and 17% were in fact RH negative, very analogous to our U.S. population. As you are probably aware that if a woman who is RH negative carries an RH positive fetus, who's inherited its RH positive blood type from its father, at the time of delivery, some of that baby's blood can escape into mom's circulation. And when that happens, mom forms antibodies to that, called anti-D. That doesn't have any consequences typically for the first pregnancy. But in the second pregnancy, if she goes on to carry another RH positive fetus, those antibodies can cross from the maternal circulation through the placenta, attach to the fetal red cells, and cause anemia. And so the disease in the baby is called hemolytic disease of the fetus and newborn. And again, these maternal antibodies, which persist for life, are sent across transplacentally and cause fetal anemia, in worst case scenario, cardiac failure and hydrops fetalis and fetal death. In the United States, back in the 1960s, as many 1 in 167 pregnancies were affected by severe rhesus disease. In 1968, two investigators at Columbia University in New York developed an immune globulin called rhesus immune globulin that after testing was introduced into the obstetrical practice in the United States. And you can see after that introduction, there was a dramatic fall in the incidence of this disease to where in 1990 we no longer record statistics in the U.S. About this disease. This has been true as far as the marked decrease in incidence in most European countries as well as Canada, where this immune globulin has been instituted. The injection is a simple injection. It's given one time at delivery. It's 98% effective. It's safe. It's not been associated with any major side effects or infections, and it seems to be well tolerated by patients. It has to be given at each delivery because, again, it's an immune globulin, not a vaccine, so it has to be repeated in subsequent pregnancies to be effective. This is a paper published in 2011 using UNICEF birth data from 2008, where they found there was over 5 million births in Pakistan. They were using the old incidence of RH negativity of 7.5%, and they noted that about 290,000 pregnancies were at risk. They had access to sales of rhesus immune globulin to the country of Pakistan. There were only 36,000 units purchased, which left almost 250,000 women untreated, and they calculated the rate of disease in fetuses and newborns of 17,000 cases. If we use the newer number from the pilot study of Lisa Pell of 17% RH negativity, you can see the numbers are much higher, with as many as 60,000 fetuses and newborns affected by this disease. This is hydroxytalis. This is a sad case in the United States that was missed. You can see the ascites and scalp edema that causes stillbirth of this child. In the pilot study in Daidu, at least it looks like there are 17 stillbirths and 27 neonatal deaths. Now, we don't know that all of these are related to rhesus disease. That will be determined at a later time, but clearly rhesus disease has a major impact, as I showed you in the US, on the rate of stillbirth. And if we look at WHO statistics from 2016, we see that Pakistan has one of the highest stillbirth rates in the world, and clearly, again, rhesus disease has some contribution to this statistic. We know from the pilot project by Lisa Pell that bedside testing in the field can be taught to healthcare workers using this Eldon card. With just a simple drop of blood, one can determine if one is rhesus positive or rhesus negative. They found that they could easily educate these healthcare workers, and they had dramatic accuracy. They even developed a phone app to confirm that, where they could send data to a central location. So blood group testing can be done in the field at a relatively cheap rate to determine what population is at risk and that would possibly need rhesus immunoglobulin at delivery. What we're proposing is the possibility of a pilot study to look at two arms. The first would be to expand on Lisa Pell's work on a prophylaxis arm, where we would target Rh negative first-time pregnant women, since they should not have antibodies, and provide rhesus immunoglobulin at delivery, which would be 98% effective. In subsequent pregnancies that were in Rhd negative women, we would screen for antibodies. We'd have to work out the logistics of that. If there were none, they would again fall into the rhesus immunoglobulin prophylaxis category. If they were present, I'd be very interested in working with physicians at your institution to consider developing a program to effectively treat these problem pregnancies. One of the hallmarks or cornerstones of this surveillance would be something called ultrasound of the middle cerebral artery Doppler. You're probably familiar with that. We helped develop that test in Houston when I was at Baylor College of Medicine, and using Doppler and color flow Doppler and pulse Doppler, one can determine the velocity in the middle cerebral artery, which reflects if it's greater than 1.5 multiples of the median for gestational age, moderate to severe fetal anemia, in a non-invasive fashion. And this is just a plot of a typical pregnancy. You can see the action line of 1.5 multiples of the median, and you can see that you can follow a pregnancy with serial values. And when it crosses that threshold, we do a cortocentesis and obtain blood. And if anemia is detected, then we would treat that fetus with an intrauterine transfusion. If we look at the procedure of intrauterine transfusion, this is data from the group in the Netherlands, and you can see in their 900 procedures, they had a 97% success rate and a 1.2% procedure-related complication rate and a 0.6% per procedure loss rate. So with experience, the success rate with intrauterine transfusions can actually be quite high. There is a learning curve to this. This again comes from the same group in the Netherlands, where they looked at 4 different operators and found that on average about 50 procedures are needed per operator to become very proficient at this, and about 10 per year have to be done to maintain proficiency. But again, my interest would be to come to Pakistan and develop this technique and teach them everything I know to build this competence at your institution. The equipment is not expensive for a program like this. The 2 GE machines we've priced out to be about, even in Pakistan, about $98,000 a piece. A portable culture counter is important to be able to run the blood counts right away, right outside the operating room door, and that's about $10,000. And then a supply cart for needles and things like that would be about $5,000. So I had a few questions before we wrap up that maybe Dr. Ajax here could jot down some notes, and maybe you could help me to try to get a feel for your particular institution. But first, let's start with how many deliveries do you do at AKU University, or AKU? And what percentage of patients do get prenatal care in your catchment area? And when do they typically start their prenatal care? What percentage of patients do get ultrasounds at some point in the pregnancy? What's the average number? And what are the ultrasound resources at your institution? How many satellite clinics are involved in sending patients to your obstetrical service for delivery? What's the general knowledge of the obstetrical community about Rh disease, its treatment and prevention, and do Pakistani physicians follow any national guideline in their country? More specifically, do pregnant women get their blood type performed routinely at their first prenatal visit? What percentage of women currently in your catchment area do get rhesus immune globulin either at 28 weeks gestation or after delivery or both? And is cord blood routinely obtained at delivery for typing the baby to see if it's Rh positive or not? Again, I thank you for your time. Appreciate this opportunity. I look forward to giving my lecture later in the week on, I think it's on Tuesday. And hope to be able to, in the future, meet you in person and to move this forward. We have talked about approaching the Gates Foundation, perhaps even the National Institutes of Health, about setting up this pilot program. And we would look forward to working with you. And again, thank you very much.